stand right behind the chair. Raise your right hand. You swear or affirm under penalty of perjury that the testimony you're about to give will be the truth and nothing but the truth.
Thank you.
Have a seat, please. And before you begin, a couple things. If you feel comfortable taking the mask off, we'd prefer that you do that, but
Sure.
as a doctor, I can tell you I've had both my shots. That helps. But we'd like you to state your full name, spelling each of your name.
Sure. So Dr. Bradford Langenfeld, Bradford, Wankhedelangenfeld.
Mr. Blackwell.
And we can just call you Dr. Langenfeld.
That's fine.
Dr. Langenfeld, did you provide emergency care to the body, to George Floyd, after he was taken to Hennepin County on the evening of May 25th?
I did.
Just by way of introduction, are you the physician who officially pronounced him dead that night?
That is correct, yes.
Were you one of the physicians who tried to save his life?
Sustained.
Did you administer care to George Floyd on May 25th, 2020?
Yes.
What were you trying to do?
We were trying to resuscitate Mr. Floyd.
To save his life?
Correct.
So why don't we learn a little bit about your background, Dr. Langenfeld. Where are you currently employed?
Currently, I'm working at Grand Itasca Clinic and Hospital. It's up in Grand Rapids, Minnesota. It's my primary practice. And I also work in Waconia, Minnesota at Ridgeview Medical Center.
And Waconia is in Carver County here?
That's correct.
Grand Rapids is several hours driving away from here.
That's correct.
Why Grand Rapids?
I was born there. It's my hometown.
It's also the hometown of Judy Garland, isn't it?
It is, yes.
Are you licensed in emergency medicine?
I have a Minnesota State medical license and I practice emergency medicine.
Would you tell the ladies and gentlemen of the jury what is emergency medicine as a practice for a doctor?
It's a very broad practice, but primarily involves taking care of patients suffering from critical ailments. Oh, sure. Critical ailments such as strokes, heart attacks, car accidents, other emergencies such as that, but also less emergent conditions, sore throats, urinary tract infections, things like that.
When were you first licensed?
May of 2020.
Would you tell the ladies and gentlemen of the jury a little bit about your educational background?
So I attended medical school at the University of Minnesota Twin Cities and then residency training at Hennepin County Medical Center.
And when did you finish your residency then?
Last summer.
Have you ever had any occasion to testify in a court before?
No, I have not.
This is the first time.
That's correct.
Let's go to Monday, May 25th, 2020, last year, Memorial Day. Do you recall whether you were working that evening?
I was, yes.
Where were you?
I was in the emergency department.
At the Hennepin County Medical Center?
That's correct.
And what was your position or title there?
I was one of the senior residents. We're involved with direct patient care, including both critical care and overseeing some of the junior residents.
Do you recall what time your shift began and ended?
It began at about 1 p.m. that day and ended at approximately 11 p.m.
And as a senior resident, what was your role?
My role was primarily direct patient care. I work underneath attending physicians as a resident.
Did you also oversee any other residents?
Yes.
Which residents would you have overseen?
More junior residents earlier in their residency training.
Now, in terms of was care administered to George Floyd on May 25th by yourself?
Yes.
Yeah. Uh, who was the person primarily responsible then for George Floyd's care in the Hennepin County Medical Center Emergency Department?
I provided the majority of direct patient care under supervision of Dr. Ashley Strobel, who was my attending physician at the time.
Were you the primary decision maker?
I was.
Were you the person responsible for much of the direct patient care?
Yes.
When Mr. Floyd's when Mr. Floyd was brought in, would you describe it as an emergency situation?
Yes, absolutely.
What was his condition in terms of his cardiac condition?
He was in cardiac arrest.
And does cardiac arrest mean that he had had a heart attack, or what does that mean?
Not necessarily.
What does cardiac arrest technically mean?
Cardiac arrest is defined as sudden cessation of blood flow to all the tissues of the body when the heart stops pumping, typically as evidenced by absence of a carotid pulse.
So in lay people's terms, if we were to say cardiac arrest means the heart stopped, would that be accurate?
Yes.
What was your immediate objective when Mr. Floyd comes in and he's in cardiac arrest? What were you immediately trying to do?
Find a way to get the heart to pump on its own again. The primary goal in cases such as this is to achieve ROSC, which means return of spontaneous circulation. And part of that process involves trying to identify the cause of the arrest to see if there's any reversible causes, and continuing CPR and other life-saving measures.
And time is of the essence?
Yes.
How did you first learn that Mr. Floyd was being transported to the emergency department at Hennepin County Medical Center?
I received we call it a Zip-It page. It's basically a EMS notification.
Now first tell us what EMS is.
Emergency Medical Services.
And a Zip-It, is it essentially a text type message, or how would you describe a Zip-It?
It's sort of like a encrypted text.
What time did the Zip-It come in?
I don't recall exactly, maybe around 8:50 p.m.
What information was provided to you for his care or treatment by Zip-It?
The information was that it was a 30-year-old unidentified male who was in cardiac arrest, and that's as much as I can recall at this time, yeah.
Do you recall whether any information was given to you as to what may have happened to him ahead of time, before he got there, to explain the cardiac arrest?
Not at the time, not before he got there.
Did you know at the time he arrived that the patient was in fact George Floyd?
I did not.
So you learned that at some point later, that it was George Floyd?
Yes.
Did you also know at the time that there was a video or any videos that depicted what had happened to Mr. Floyd before he was transported to the Hennepin County Medical Center on May 25th?
No.
Grounds? Overruled.
You can answer. Were you aware of the existence of any videos as to what may have happened before he arrived at Hennepin County Medical Center on May 25th?
No.
Did you subsequently learn about videos?
Yes.
Were you able to evaluate your assessments about George Floyd in light of the videos?
Yes.
We'll talk about those a little bit later. So when you received this Zip-It, what did you do in response to it?
We prepared a bay in our stabilization room, which is essentially a large room with a lot of critical care resources. We sort of prepped a team and got ready to take care of the patient when he arrived.
Do you recall roughly what time Mr. Floyd would have arrived in the emergency room?
approximately 8:55 p.m.
And when he arrived, then had CPR been started?
Yes.
Any mechanical devices or other things being used to help to stabilize it?
Yes, there was a Lucas CPR device, which is basically a mechanical device that sits across the body with something that almost looks like a plunger and pushes against the chest to provide CPR or chest compressions.
So this Lucas device then was on Mr. Floyd when he arrived in at the hospital.
Correct.
Did you ever observe at any point in time that his heart was beating on its own?
Not to a degree sufficient to sustain life.
Do you recall who brought Mr. Floyd into the emergency department?
I do recall 2 paramedics and possibly 1 or 2 other people, but I don't remember exactly.
Do you recall whether there were any police officers there also?
I don't personally recall that, no.
Did the paramedics who arrived at the emergency department give you a report?
They did.
Do you recall what they said for purposes of treating Mr. Floyd?
I do. The report they gave us is that they were called to a scene of someone who was suffering from medical emergency. As I recall, and this is what I was told at the time, they were initially called for a lower type of acuity event of facial trauma, and then that was upgraded to an individual in distress. They reported that on their arrival, the individual did not have a pulse and CPR was started. They placed an eye gel, which is a supraglottic airway device. It's basically
A super what device?
supraglottic airway device. It's just a sort of a tube that goes down into the throat and can ventilate the lungs. And then they gave medications, including epinephrine and sodium bicarbonate, to try to resuscitate Mr. Floyd as CPR was ongoing.
Did they tell you that Mr. Floyd was in police custody?
They did mention that he was being detained at the time.
Now, did you recognize either one of the paramedics who came in?
I did. I did recognize both of them, and I worked with one of them several times before.
Derek Smith, did you know a Derek Smith?
I believe so, yes.
And do you recall having worked with a Derek Smith before?
I do.
How often?
Several times throughout the course of my training.
When the paramedics bring a patient in to the emergency department, is it standard protocol for them to tell you why they are bringing the patient in? What's the emergency?
Yes.
In what the paramedics told you when they brought in Mr. Floyd, did they also then give you information when they brought Mr. Floyd in?
They did. They essentially gave the report that I just told you, yes.
Did they say to you, for purposes of caring or giving treatment to Mr. Floyd, that they felt he had suffered a drug overdose?
Not in the information they gave, no.
Did they tell you in the information they gave that they felt that Mr. Floyd had had a heart attack?
No.
Did you receive any information or indication from the paramedics when they brought Mr. Floyd in that anyone had attempted CPR on Mr. Floyd at the scene on May 25th, 2020?
Overruled.
I did not receive a report that Mr. Floyd had received bystander CPR, no.
Did you receive a report that he had received CPR from any of the officers who may have been on the scene on May 25th, 2020?
No.
Is the administration of CPR right away important for you to know when you're dealing with a patient who has suffered cardiac arrest? Is it important for you to know about that?
It is, in the sense that it informs the likelihood of survival.
And what do you mean by that, Dr. Langenfeld?
It's well known that any amount of time that a patient spends in cardiac arrest without immediate CPR markedly decreases the chance of a good outcome. Approximately 10 to 15% decrease in survival for every minute that CPR is not administered.
Did the paramedics then tell you anything about the care that they had administered to Mr. Floyd?
Yes.
Can you tell us what they told you?
That they had started CPR and placed that airway device and started bagging the patient, as in providing breaths, and then administering those drugs. Yes.
And so when you talk about bagging the patient, could you describe what that is?
Yeah, it's called a BVM, or a bag valve mask. It's essentially a device that's hooked up to oxygen on flow to simulate giving a breath, or mouth to mouth, as it might be more better understood. But yeah.
Did the paramedics start something that's referred to as the ACLS algorithm?
Yes.
Would you tell the ladies and gentlemen of the jury, what is the ACLS algorithm?
So ACLS stands for Advanced Cardiac Life Support. It's basically a standardized way of taking care of patients in cardiac arrest.
And so these are protocols, or sort of a checklist process you go through when somebody shows up in cardiac arrest?
Correct. It's a little broader than that, but a big part of it is for folks in cardiac arrest, yes.
Is it to help you to determine why the person might be in cardiac arrest so you know how to treat them?
Yes.
Have the paramedics tried to resuscitate Mr. Floyd?
Yes.
Do you recall how long?
The report we received was for approximately 30 minutes.
Now, you had mentioned to us just a moment ago that they had administered epinephrine and sodium bicarbonate. Would you tell the ladies and gentlemen of the jury, what are those administered for?
Epinephrine is colloquially known as adrenaline. It's a drug that has been studied extensively and is part of the standard protocol for ACLS. The evidence on it is somewhat controversial, but it is part of the standard protocol. Sodium bicarbonate is a medication that may provide some buffering of the acidic environment in the blood that occurs during cardiac arrest, and that is perhaps a more controversial medication than epinephrine.
Did the paramedics tell you whether they had checked Mr. Floyd's heart function?
Yes.
Well, let me ask that a different way. I want to talk to you about two different kind of heart functions and see if you can describe what they are to the jury, and how or if they relate to Mr. Floyd. The first one we refer to as PEA. Do you know what PEA refers to?
Yes. So PEA refers to pulseless electrical activity. It's basically a situation where someone is in cardiac arrest. They do not have a pulse, as we previously discussed, and they do have some electrical activity on the monitor. And that suggests certain underlying causes that are known to be more common. The most common cause of someone being in PEA arrest, the most common causes are hypovolemia, either from typically bleeding or from hypoxia or low oxygen.
So we'll talk about those in more detail. But was Mr. Floyd in PEA status, pulseless electrical activity, when you saw him on May 25th?
He was, yes.
And there is another term I'd like to talk about and have you explain to the jury, asystole, I think it's called. Am I pronouncing that right, by the way?
Asystole, ma'am.
Yes. Would you spell that for ladies and gentlemen of the jury?
Asystole.
And what is that, Dr. Langenfeld?
It's probably best known as flatlining, where there's no cardiac activity on the cardiac monitor and the patient is in cardiac arrest.
And so was Mr. Floyd in asystole status also when his body was brought into Hennepin County Emergency Department on May 25th?
At some point, yes, there was report that at some point he was felt to be in asystole prior to arrival.
And was he, and asystole meaning flatline, was there any point in time during your treatment of care on May 25th that Mr. Floyd was anything other than flatlined during your care and treatment of him?
There were times, for the majority of his time in our emergency department, he was in PEA arrest. Ultimately, that did devolve into asystole.
Is pulseless electrical activity, PEA arrest, asystole, are those conditions of the heart where you can simply apply a shock and potentially bring the patient back?
No.
What are what we refer to as shockable rhythms? Is there such a thing as a shockable rhythm?
So typically these are thought of as either ventricular tachycardia or ventricular fibrillation, which are basically abnormal rhythms of the heart that are more commonly associated with cardiac arrest, specifically from a heart attack. And they are rhythms that you can administer electricity to and shock a patient back into a normal rhythm.
But Mr. Floyd didn't have ventricular fibrillation or ventricular tachycardia.
Correct.
Because his heart wasn't pumping.
Yes, because he did, yes. In both situations, it's a little more complicated than that, but yes, he was not in VFib or VT as we commonly call them.
Do you recall, were there still handcuffs on Mr. Floyd when he was brought into the emergency department?
I don't specifically recall if they were on when he immediately arrived, but it would be unlikely because he had the Lucas CPR device on, and I recall his hands being at his sides.
Do you recall with his hands at his sides whether there were indentations or marks on his wrist?
At the end of the case, yes, after he was declared dead.
What did you observe in that regard?
I'm sorry, can you repeat?
In terms of any indentations on his wrist or markings on his wrist?
I inferred that it was from handcuffs.
So let's talk about then the care you then provided once the paramedics have brought Mr. Floyd to the emergency department. What did you do?
So immediately on arrival, we took report from the paramedics. Mr. Floyd, as we knew him at the time only as an unidentified individual, was transferred over to the bed in the emergency department. As I recall, multiple things typically will happen simultaneously in these cases, but we achieved additional access. I placed intraosseous line in his bone in his leg.
Would you tell the ladies and gentlemen of the jury what interosseous
It's
means?
basically a type of IV that goes in through the bone and injects fluid or medications directly into the bone marrow, essentially. It's a type of access that's easier to achieve in someone who's in cardiac arrest.
And did you also go through the advanced cardiac life support protocols?
Yes, so simultaneous to that and obtaining blood draw and continuing chest compressions, etc. It went through various different things that could be causing this. Commonly in the ACLS protocol, these are thought of as the H's and T's, specifically with regard to the PEA asystole algorithm.
Well, let's, if we could, take a look at the H's and the T's.
Sure.
So, Brett, if you could pull up, I think, 900. I'm showing you what's marked as Exhibit 900 for illustrative purposes.
Sidebar?
Dr. Langenfeld, um, going back to Exhibit 900, on the H's and the T's, which were part of the protocols for advanced cardiac life support. Could you briefly explain to the jurors what the H's and T's are?
So these are common reversible causes of cardiac arrest in individuals, typically in PEA or asystole cardiac arrest. A lot of these etiologies are perhaps best evaluated through an ultrasound-based approach, but I can go through all of these. So hypovolemia, typically hemorrhage or bleeding, so we would think of that more in a traumatic cardiac arrest. Hypoxia, low oxygen, again, those being the two most common causes of PEA asystole arrest. Hydrogen ions, acidosis can be from any number of causes, but essentially where the pH in the blood gets so low that the heart cannot function. Hyperkalemia is low or high potassium, it being a very important electrolyte for proper cardiac function, and disturbances on the extreme can lead to cardiac arrest. Hypothermia, very cold. Toxins, there's a lot of different toxins that can cause cardiac arrest.
And that's from poisons to potentially drugs.
Correct. Tamponade specifically refers to fluid around the heart that can prevent the heart from filling and then lead to the heart stopping. Tension pneumothorax is air around the lung, between the lung and the chest wall, that essentially expands to the point where it prevents blood flow from returning to the heart, and therefore leading to cardiac arrest. Cardiac thrombosis specifically can refer to a heart attack or a ruptured plaque in one of the coronary arteries of the heart. And then pulmonary thrombosis or pulmonary embolism is a blood clot in the pulmonary arteries that prevents blood from flowing from one side to the other of the heart, and therefore leading to the heart no longer functioning.
You mentioned ultrasound. What is the role of ultrasound in studying or trying to assess the cause of cardiac arrest?
Ultrasound can be used to evaluate many of these different causes. I think people would be most familiar with ultrasound from movies where they look at the baby using an ultrasound device or a small probe on the abdomen, but it's the same technology. So we can look at the heart directly and see if there's fluid around the heart, for example. We can evaluate for a large right ventricle that might be suggestive of a pulmonary thrombosis due to increased strain on that side of the heart. We can look for evidence of hemorrhage, hypovolemia, by looking in the abdomen to see if there's any bleeding or bleeding elsewhere. We can look for evidence of tension pneumothorax. For example, we can evaluate for what's called sliding signs on both sides of the chest that would suggest that the lungs are up and are there's no air between the lung and the chest wall. So we can use it to...
That the lungs are properly inflated then.
Exactly, yep. So we can use it to evaluate for a large number of these etiologies.
So you went through the protocols of the H's and the T's. Did you have any kind of leading theories for treatment purposes as to what the most likely causes were for Mr. Floyd's cardiac arrest?
I felt that I was able to determine that some etiologies or causes were less likely based on the information that I had both from the paramedics and also the information I was able to obtain from my exam and ultrasound, etc. At the time, based on all the information I had, I thought it was less likely that the patient had suffered from, for example, cardiac tamponade. There was no fluid around the heart. Tension pneumothorax. we can discuss that briefly. At one point in the case, I was concerned that he may have developed a tension pneumothorax, but I felt it was unlikely. We did, in fact, perform bilateral finger thoracostomies where we entered the chest.
Let's ask another question.
I'll ask
including
another question. You were explaining to the jury that you thought it was not likely a cardiac tamponade. Then you're explaining why you thought that tension pneumothorax was not likely.
Correct.
And could you, in plain English, help the jurors to understand how you might have eliminated that?
We essentially used a scalpel to cut into the chest and create a hole between the chest and the potential space around the lungs. We did not appreciate any large gush of air that might suggest that there was air in that potential space.
Was there anything that you looked at to determine whether or not the cardiac arrest was likely or unlikely to be related to Mr. Floyd having had a heart attack?
A lot of that is based on the history that we received from paramedics. There was no report that, for example, the patient complained of chest pain or was clutching his chest at any point or having any other symptoms to suggest a heart attack. That information was absent. Also, the fact that he was in PEAA systole, as I was told on the initial rhythm check, further decreases the likelihood of that possibility. At the time, it was not completely possible to rule that out, but I felt that it was less likely based on the information that was available to us.
Did the ultrasound play any role in the question of whether or not he did or did not, or was likely not to have had a heart attack?
No, not especially in this case, no. Did not.
Did you consider the possibility of toxins, for example, being responsible for Mr. Floyd's cardiac arrest, including potentially drugs?
In the sense that it might have informed our care, yes. There was, again, no report that this patient had, for example, overdosed on a specific medication such as calcium channel blocker or any other medication for which there might be a very specific antidote. And so in that sense, I didn't feel that there was a specific toxin that we could give a medication for that would readily reverse his arrest.
And what about then hypoxia?
So hypoxia being, again, one of the most common causes of PEAA systole just in general. I did then, as I'd mentioned, use the ultrasound to look in the abdomen and did not see any evidence of hemorrhage. There was no obvious significant external trauma that would have suggested that he suffered anything that could produce bleeding sufficient to lead to a cardiac arrest. And so, based on the history that was available to me, I felt that hypoxia was one of the more likely possibilities.
And hypoxia as an explanation for his cardiac arrest, meaning oxygen insufficiency.
Correct.
Did you have any other leading theories as to why Mr. Floyd's heart may have stopped other than oxygen deficiency?
Yes. I also considered an acidosis. In particular, excited delirium, which is a controversial diagnosis, but it was in the differential in this case.
And were you able to make any assessments about so-called excited delirium based on your examination of Mr. Floyd?
Again, the patient had been in cardiac arrest for 30 minutes. It can be difficult based on the examination. Certainly there was no report that the patient was ever very sweaty, which is often the case when thinking about excited delirium. There was no report that the patient had ever been, that Mr. Floyd had ever been extremely agitated. In my experience, seeing a lot of cases of mental health crises or drug use leading to severe agitated states, that is almost always reported by paramedics. And so the absence of that information was telling, and that I didn't have any reason to believe that that was the case here.
So how long was Mr. Floyd in your care in the emergency department?
Approximately 30 minutes.
And at the end of the 30 minutes, did you pronounce him formally dead?
Yes.
At the time you pronounced him dead, was he still in some degree in PEA or asystole in terms of describing his heart?
I think it's probably best to think of these as sort of a spectrum where PEA is some degree of electrical activity still running through the heart, but the heart's not pumping. And then eventually that will devolve into asystole, where both the heart is not pumping and then the electrical activity stops as well. And so at the end of the case, Mr. Floyd was still in PEA, but there was virtually no cardiac activity. And at that point, in the absence of any apparent reversible cause, and because Mr. Floyd had been in arrest for, by this time, 60 minutes, I determined that the likelihood of any meaningful outcome was far below 1%, and that we would not be able to resuscitate Mr. Floyd, and so I then pronounced him dead.
And doctor, was your leading theory then for the cause of Mr. Floyd's cardiac arrest oxygen deficiency?
That was one of the more likely possibilities. I felt that at the time, based on the information I had, it was more likely than the other possibilities.
And doctor, is there another name for death by oxygen deficiency?
Asphyxia is a commonly understood term.
Thank you, Dr. Langenfeld. No further questions.
Mr. Nelson. Yep. Since 9 o'clock, so we're going to take our 20-minute mid-morning break. Thank you. We get our doctor back.
We do, Your Honor.
And Mr. Blackwell, I forgot to plug in my headset, so it's a Monday. And just a reminder, Doctor, you are still under oath. Mr. Nelson.
Good morning, Doctor.
Good morning.
Thank you for being here today. I have a few follow-up questions for you, kind of picking up right where we left off. You were discussing hypoxia kind of being consistent with asphyxiation, right?
Correct.
Hypoxia is the lack of oxygen to the brain, correct?
Correct.
And there are many things that cause hypoxia that would still be considered asphyxiation, agreed?
Correct.
Drug use, certain drugs can cause hypoxia, agreed?
Yes.
Specifically fentanyl.
That's correct.
How about methamphetamine?
It can.
Combination of the two?
Yes.
All right. Now, you testified about certain things that happened during your care of Mr. Floyd. You were running all sorts of different tests. You used the
Ultrasound.
Ultrasound.
Yep.
Thank you. Used the ultrasound. You took some blood samples as well,
Correct.
and you took some blood gas samples as well. Correct?
Correct. From the blood samples. Yes.
So can you explain what the blood gas samples are?
So the blood gas samples are analyzing different parts of the blood, specifically looking at the pH, or how acidic or basic the blood is, looking at the amount of oxygen in the blood, the amount of carbon dioxide, the amount of bicarbonate.
Okay.
different
And
things.
carbon dioxide levels in this case were pretty high, weren't they?
Correct.
Do you recall what the carbon dioxide level was in the blood gas sample you initially took?
I believe the initial blood gas sample I took was a venous blood gas sample, which is less preferable as opposed to an arterial blood gas sample. At the time, I believed it was a venous sample, and I believe the CO2 level in that sample was around 100.
Okay. A little over 100 perhaps?
Yeah.
And that indicates an exceptionally high carbon dioxide level, agreed?
That, yes.
What would the average, for a healthy person, and you did a blood gas sample, what would you expect the CO2 or carbon dioxide level to be?
For a healthy individual without any sort of lung disease, you would expect somewhere between 35 and 45.
Okay. And so Mr. Floyd's carbon dioxide level was more than 2 times what you would normally expect.
Correct.
Now, the reason that you're doing these blood gas samples is in part to help you analyze and figure out courses of care, agreed?
Yes.
And that's the carbon dioxide number that we're talking about is essentially, that would be indicative of a person who is not eliminating the carbon dioxide, right? For it to go that
Correct. For it to be high in the blood, that means that they are therefore not eliminating it through ventilation or breathing.
And that points to a possible respiratory problem, right?
It can, yes.
And that increase in a carbon dioxide from a 35 to 45 to over 100, that takes some period of time in order to climb that high.
Yes, it can happen relatively quickly depending on how severe the ventilation problem is, but
But it could take 30, 40, even an hour to climb that high.
it could take that long. It could take much less time, yes.
The use of fentanyl, do you know that to attribute to high carbon dioxide levels?
It can cause high carbon dioxide levels because it depresses the ventilation or the breathing.
So when someone ingests fentanyl, it can cause them to feel very sleepy because of an increased carbon dioxide level. Agreed?
Correct.
And that's one of the reasons ultimately that fentanyl is so dangerous, because it suppresses the respiratory system. Agreed?
The primary reason it is so dangerous. Yeah.
Now, you testified that when the paramedics gave their report to you, they did not give you any reference as to potential drug use, correct?
Correct.
They did not tell you that they had administered Narcan or naloxone during their care, correct?
Correct.
And during the course of your care of Mr. Floyd, you did not administer Narcan or naloxone, did you?
No.
And when you talk about those drugs that are immediately able to reverse the effects, that's what that does. Narcan reverses the effects of fentanyl toxicity. Agreed?
Correct.
When someone has a high carbon dioxide level, that causes that person to have a sensation of shortness of breath. Agreed?
Yes.
And that can happen to a person even without stress complicating their body, right? That respiratory, that feeling of an inability to breathe.
Yes.
Are you familiar with the impact of taking certain narcotics interrectally, rectally?
Yes.
And that ultimately can provide a more powerful or rapid onset of an impact, right?
Yes.
Simply because a person has a history of chronic opiate abuse, does that mean that fentanyl can't kill them?
No.
When someone is hyperventilating, anxious and hyperventilating, they're actually decreasing their CO2 by doing that, correct?
Correct.
Some of the considerations that you have to take also would be the potential occlusion of a coronary artery, right?
Yes. In cases of cardiac arrest, yes.
And someone who has greater than a 75% occlusion of the right coronary artery, that poses a particular risk of fatal ventricular cardiac arrhythmia, does it not?
Objection, Your Honor. May we approach?
All right, last question is withdrawn. Ask a new question.
Only a physician can declare a person dead, correct?
Depends where you're practicing.
In the state of Minnesota?
Yes.
A paramedic can't declare a person dead.
No, not without consultation with a physician.
So just to, based on your treatment, again, of Mr. Floyd, Mr. Floyd, based on these tests that you did, had an elevated CO2 level, correct?
Yes.
And that CO2 level was considered to be exceptionally high, correct?
Correct.
And you did not, in the course of your consideration, provide naloxone or Narcan.
No.
Okay. And it would be, is it fair to say that the administration of Narcan, if you do not have opiates in your system, is a safe procedure?
Yes.
And if you do have opiates in your system, the administration of Narcan could be life-changing, life-saving.
Yes. Not in this case.
Prior to the, but again, the paramedics also, based on your information, did not administer Narcan.
Correct. Can I make a clarification?
I'm good. No,
No.
there's no question.
You can clarify and redirect.
If they wish.
Basic, I'm sorry?
You said the state can clarify and redirect.
Direct if they wish.
And you would agree that Mr. Floyd arrived at HCMC at approximately 8:53? If we have seen evidence previously.
That sounds correct. Yep.
I have no further questions, Your Honor.
Okay, Mr. Blackwell.
Thank you, Your Honor. For starters, Dr. Langenfeld, there was an answer you wanted to clarify. Please do so.
Only to state that Narcan, administering Narcan to someone who potentially suffered a fentanyl overdose, once that individual is in cardiac arrest, the administration of Narcan would provide no benefit.
And Mr. Floyd was obviously in cardiac arrest.
Correct.
You were asked questions just now about whether fentanyl works by causing someone to feel very sleepy. Remember that discussion?
Yes.
Did the paramedics tell you that Mr. Floyd was ever asleep or sleepy or anything that sounds like sleep?
The report that I received was that the patient, Mr. Floyd, was unresponsive on their arrival and did not have a pulse. And so there was no report that he had been sleepy or difficult to arouse per se.
You asked quite a number of questions about the carbon dioxide content in the blood gases. First off, if a person is suffering from hypoxia, that is oxygen deficiency, is that an explanation for a heightened carbon dioxide content in the blood?
It can be in severe cases.
In this case, do you find that the carbon dioxide reading for Mr. Floyd is really all that significant?
I felt that it was weak evidence in support of what I was thinking at the time. What's difficult in cases of cardiac arrest is once someone has been in cardiac arrest for an extended period of time, essentially the blood gas that I obtained could be consistent with cardiac arrest from any number of causes. You expect the pH to be low during cardiac. I'll provide a little bit of explanation on that. During cardiac arrest, there's no blood flow to the tissues, therefore there's no oxygen getting to the tissues. Therefore, the cells will die. They'll release hydrogen ions, which lower the pH, creating an acidic environment. They'll release lactate, which complicates that further. Because the person's heart has stopped from whatever cause, they'll no longer be breathing either. And so you would expect that their CO2 to be high. Again, it can vary a little bit depending on the cause, but in my estimation, the blood gas in this case wasn't very strong evidence for one cause over another as far as the etiology of the arrest.
And it was simply consistent with the fact of cardiac arrest,
Correct.
the fact that the heart had stopped.
Correct. And I felt that the high CO2 may have suggested a respiratory cause.
Now, you were asked questions about somebody administering narcotics interrectally. Remember those questions?
Yes.
Did you get any indication that Mr. Floyd had administered narcotics interrectally?
I had no information to suggest that.
Dr. Langenfeld, thank you.
Any further? Thank you, doctor. You may step down.